Good morning. Well, you've seen on all the various maternal morbidity and mortality slides venous thromboembolism, VTE, so you couldn't get to the break without talking about it. So that is what I'm here to do. So today we're going to talk about the problem, the solution, the impact, both the intended and unintended consequences, and then what are the knowledge gaps. So, in all of the various different explanations that you've seen of maternal morbidity and mortality, we've seen that venous thromboembolism is high on the list. This is the 2023 CDC statistics, and you see that venous thromboembolism is high on the list. And this is not a surprise. We're talking about mostly venous disease. We're talking about mostly VTE, about a quarter is PE, and pregnancy is certainly a very high-risk time. The pregnant woman is 3 to 4 times or 5 to 6 times more likely to get a VTE than the non-pregnant woman, and there's a 4-fold increase with cesarean versus vaginal delivery. And pregnant women are certainly predisposed to this. It's sort of like a perfect storm. You have venous stasis, you have pelvic vein compression with the gravid uterus. You have changes in pro and anticoagulant factors, platelet signaling, and just about everything else that you could imagine. When you think about risk factors for VTE in the general surgical population, there are good risk scores, and you get a pretty good idea of who to treat. This is in a very good review article that is a compilation of various different studies that looks at risk factors in the pregnant population. And I don't expect you to be able to read every single one of these. But what I'll tell you is a couple of things. First of all, the data isn't great. The associations are often fairly weak associations. Second of all, there are different categories that you might expect: maternal characteristics, pregnancy characteristics, delivery characteristics. Certain things come up over and over again. High BMI, particularly in the setting of antepartum and immobility. Things like preeclampsia, things like delivery characteristics when you get an infection with a cesarean delivery or a vaginal delivery. One thing that does come up over and over again, and is really highlighted in one of these bundles that you've heard so much about, is that risk assessment is not a static entity. You need risk assessment before pregnancy, if you're hospitalized as a pregnant patient antepartum, if you have a peripartum event, and then postpartum, again, risk assessment for VTE. So what is the solution for this? And by the way, this is a problem. Certainly if you have a PE, you can die. But even if you just have VTE, you can have post-thrombotic syndrome and major morbidity as a result. A lot of our solution has been driven by the UK. And I'm purposely showing you a truncated diagram now. This is the EMBRACE data, the triennial reviews that you saw from Elliott Main, and they are looking at the UK maternal morbidity and mortality. And what you can see by these green arrows are 2 naders in morbidity and mortality from VTE, 2006 to 2009 and 2012 to 2014. What happened during these times? Really what happened was attention on thromboprophylaxis. And everyone was watching when this happened. What was done? Well, mechanical compression boots have been around for quite a long time, but there are some problems. First of all, people don't use them consistently. They're annoying, and people tend to turn them on and turn them off, and even those of us who still use them as part of postpartum, particularly post-C-section thromboprophylaxis, know that they're not used consistently. There's not a lot of data on these, but the data that does show shows that you actually have to keep them on. So what the UK did was focus on pharmacologic thromboprophylaxis, particularly heparin. Now I'm going to take you to the right-hand column to low molecular weight heparin, because that's where most of Europe goes. And you can see that that column is a lot longer. Why? Because it's ease of administration, better bioavailability and safety profile, more predictable dosing, lower incidence of heparin-induced thrombocytopenia, perhaps fewer bleeding episodes, and we'll talk in a few moments about the data on that, and lower incidence of osteoporosis. We in the United States, particularly we in the anesthesia community, have a bit of a penchant for unfractionated heparin for a couple of reasons: shorter half-life. We talk about protamine for urgent reversal, but it's not really indicated or recommended for neuraxial anesthesia use. So what are the recommendations that came out of the UK's experience? Well, the Royal College of Obstetricians and Gynecologists had recommendations, and then they revised their recommendations. And then the American College of Chest Physicians also had recommendations, and as did the American College of Obstetricians and Gynecologists, as did the California Maternal Quality Care Collaborative that we heard about from Elliot Main, and did the Europeans, and guess what? They were all different. There are many articles about how different all of these guidelines are. I still like this one, which is almost a decade old at this point, because this took the same 293 women postpartum after C-section and said, what would these guidelines suggest as to whether or not to do postpartum thromboprophylaxis? And these are the percents of these same women who would get postpartum thromboprophylaxis. 85% ARCOG, 35% chest, and 1% ACOG. So what does this all lead to when you talk about the impact of what we're doing? Well, I showed you this graph before, and this is the graph now. This is the latest triennia in the EMBRACE UK data. Not what we hope to see. And they are really good at this. They, by and large, have one set of guidelines, unlike ours. Back originally in 2014, when Cochrane did their meta-analysis and systematic review, and we know that the Cochrane reviews are almost always say insufficient evidence. They said, in fact, insufficient evidence of the current practice of thromboprophylaxis for VTE to show that it had an effect. Fine. So now we have an updated systematic review and meta-analysis from just a couple of years ago. The current literature provided an insufficient sample size to conclude whether postpartum VTE rates differ between those exposed to postpartum pharmacologic prophylaxis and then those unexposed. And this is in part due to the fact that although it remains a significant cause of maternal mortality, it is still a relatively rare event. And all of these different protocols are really contributing to the fact that it is really hard to tell what is making a difference and what is not making a difference. This is some trend data in the US from some administrative data sets. Just to orient you, the top is for DVT over time, the bottom is for PE, the red is for cesarean delivery, the blue is vaginal delivery. What do we see? This is taking us to relatively contemporary data. We see perhaps a decrease In the incidence, this is now per 10,000 deliveries. The UK data is typically per 100,000 deliveries. Perhaps we're seeing a decrease in the rate of DVT for cesarean deliveries up above, not in vaginal deliveries, and we look at PE, if anything, an increase in both for cesarean delivery and vaginal delivery, despite our best efforts. So what's going on? Well, we'll see in a minute we have increasing risk factors. That's not helping. We've talked about increasing mortality overall, and these underpowered studies looking at heterogeneous populations. This is a nice study, elegant, about prevalence of postpartum venous thromboembolus risk factors in an Irish urban obstetric population. A couple of things came out of that. A contemporary view, this is 21,000 consecutively sampled women, a contemporary view of some of these risk factors that we're talking about. Certainly overweight and obesity, age greater than 35, and cesarean delivery, which has always come out as a risk factor. And then I will show you this next part pictorially, but 3/4 had at least one risk factor, more than 40% at least two, and a fifth developed risk factors peripartum. And this is what this looks like. So in the green are the patients postpartum who didn't have any risk factors. In the red are patients who just actually manifest their risk factors postpartum. And in the yellow, at least one risk factor. And remember, these risk factors are increasing over time. What is the unintended impact of all of this heparin and all this treatment and all of this variability? Well, obstetric bleeding. I have to say, I of course reviewed the recent literature for this talk, and it's really hard to get a handle on bleeding, and I see Elliot shaking his head. Some say yes, some say no, some say heparin unfractionated is worse than low molecular weight. Heparin, a recent multi-center cohort of 17 hospitals, fairly contemporary, showed that postpartum thromboprophylaxis was not associated with bleeding complications. And needless to say, it probably depends to some extent on the dose and how it's used. Since we are, many of us, anesthesiologists, I have to spend just a few moments on anesthetic bleeding and what we worry about. This is a picture of a spinal epidural hematoma. Now, in general, and this is just a summary of some of the largest studies, we are lucky. Obstetric patients are at extremely low risk for spinal epidural hematoma, on the order of 1 to 200 or 250,000, unlike an elderly surgical patient who could be as high as 1 in 3,600. We did a pretty extensive review of the literature to see whether patients getting thromboprophylaxis, low dose, had an increased incidence or actually number, because we don't know the denominator of spinal epidural hematomas. We did not find any cases of patients just on low dose thromboprophylaxis. There were a couple of cases where there were confounders. And we also looked at the closed claims data that were available to us. No cases just from low dose thromboprophylaxis. This is an updated literature review, very similar. And both cases, there were confounders. One had multiple attempts, which is typically thought of as being a risk factor in and of itself, and another had multiple anticoagulants. The details were not enumerated. That said, we know that there's underreporting. So just a show of hands out of curiosity, how many people know of patients who you found out afterwards had a neuraxial anesthetic with an anticoagulant on board actively? I certainly do. And how many people actually know of a complication that was associated with it? I have to say I do too in a non-reported case. So we can be comfortable that this is not wreaking havoc, that we are not having a rash of spinal epidural hematomas, but the issues are probably more than are actually reported. Again, we have evidence, although incredibly scant evidence on incredibly small numbers of patients, that our obstetric patients metabolize and process, and the pharmacokinetics and dynamics of these medications in pregnancy are different. This is one of the famous tiny little studies on 6 patients, pregnant, 6 patients who weren't, who got unfractionated heparin, about 9,500 units. And if you look at the upper graph, that represents the plasma heparin concentration on the left and the APTT on the right, of the non-pregnant on the top versus pregnant on the bottom, an attenuated effect. And this next study was for enoxaparin, a single dose. And again, I will raise on the left, the vertical axis is anti-10A activity. The horizontal axis is time. Above is non-pregnant. Below the darker blue line is pregnant term, an attenuated effect. I will just point out here that the new ASRA guidelines talk about a threshold level if you're going to check anti-10A levels of less than 0.1. These values are not less than 0.1 for any of these patients at the 12-hour mark for this low dose. I digress, but I thought you'd be interested to see. So it was important for us all to get together because all of this is happening and we're all doing it separately. So we brought together with SOAP not only our ASRA colleagues, but our OB colleagues in SFM and ACOG and ASH, and together we made guidelines to do a couple of different things. One was to lay out what we're not going to go through in detail now, but were the elective, best case time delays based on half-lives and to some extent influenced by case series and reports in non-pregnant patients for unfractionated heparin and for low molecular weight heparin between a dose and when the patient could have their neuraxial procedure. Probably more importantly for this group, we with ASRA agreed that our pregnant patients, whereas we probably couldn't make a whole set of guidelines that were different, we definitely needed to have discretion with our pregnant patients, that the risks of not doing the procedure were different than in the general population. There needed to be discretion and a different weighing of risk and benefits. And of course, always with any recommendation, it is not a legal precedent and it does not replace clinician judgment. Probably the most important thing about the guidelines, and still to this day, is that we need to plan and we need to work together. We need to know which obstetric guidelines we're using on our labor floors, and we need to know which patients are getting what. Everyone should be on the same page about what the time interval weight guidelines are, because they are the same now, really, SOAP, ASRA, ESA, all the different organizations. We need a way to identify patients who are on these anticoagulants, ideally flags in the EMR, ideally the question at a timeout, even for a labor epidural. And there need to be discussions and protocols for when patients who are on anticoagulants call in to say, I think I'm in labor. What do they do? The expected circumstances are one thing, the unexpected are others. I will say that in Europe and more in the US, people are not bridging with unfractionated heparin. The patients are more and more on low molecular weight heparin. We do not have data how well it's working out. It seems to be okay, but it would be wonderful to have data. So let's get back to VTE to finish up. What are we going to do with this morass of using heparin, not knowing if it works? Well, there are two studies that I think are going to be really helpful to us. The first is called the HILO study, which I have been following for years, since the protocol first came out. This was a very large open-label study that was specifically looking at, in high-risk patients who had had a VTE, is it better to do larger doses of heparin? Because we know that some places and some patients get low dose, which is one thing for us, and others get weight-based dosing and such that means a whole other set of things in terms of much longer wait times. Often in low molecular weight happen the difference between 12 and 24 hours. So which is better? This study published in The Lancet, 70 centers, 9 countries, contemporary over the last almost decade, 13,000 patients, looked at both VTE and bleeding. VTE occurred at about 1% in both the low dose and the intermediate weight-based dosed heparin prophylaxis. There was about 4% major bleeding, as they called it, in both groups, so no difference. And they concluded there is no reason to use weight-based. That was their conclusion. And then this study, which at this point is a feasibility study. They wanted to say, is it actually possible, given the variability in practice, to be able to do a definitive study as to whether this heparin prophylaxis is actually working? And we don't have to go through all the details of the study, but basically they showed that they were able to do enrollment and randomization and follow-up, 3-month follow-up, at a rate that was better than they predicted. They exceeded expectations. Of note, for this small pilot, they saw neither major bleeding nor VTE, but it is just a pilot. And this will hopefully be the next study published in The Lancet, and I'll have a different talk the next time I come to talk. So we have remaining knowledge gaps, and I'll go through them quickly. Validation of the prediction tools in terms of absolute risk for individual patients. The optimal risk threshold at which we should initiate thromboprophylaxis in the first place. The optimal dose, although I think HILO study perhaps gets us closer. The optimal duration of therapy. The bleeding risk. Is it something we have to worry about? And the impact of expanded thromboprophylaxis on what so many of us do, obstetric anesthesia. This is just a little chart I will conclude with that is from a recent opinion piece in the British Journal of OBGYN in 2025. And it basically, in summary, says they suggest about a 1 to 2% risk tolerance, and antenatally and postnatally to use some patient decision-making, shared decision-making, which is, of course, the buzzword now, but at least when you're talking to your patients, let them know of the data. Let them know that this is not something that is ironclad. And absolutely, let's get some good data. So I thank you. I look forward to all of your comments in the discussion section.